Hey guys, welcome to case 7. This is a neuro case. Let's get started. So we have a 50-year-old man comes to the physician because of worsening involuntary movements in both arms for the past 5 months. His father had a similar condition and was treated with medications. The patient is anxious and vitals are within normal limits. Examination shows a low amplitude tremor bilaterally, when the arms are outstretched, that worsens when reaching out to grab a pencil. Muscle strength and tone is normal. Deep tendon reflexes are 2+ bilaterally. So that's normal too. His speech is normal in rate and rhythm. Which of the following is the best next step in management? And over here I've included a diagram of this patient being asked to draw a spiral. So this is our patient over here on the left, and this is a normal person over here on the right. So I'll give you a second to pick an answer choice, and then we'll go through them together. So you can pause the video now. Alright, so if you picked propranolol therapy, you are correct. This patient over here has what we call an essential tremor. And we're going to be going through all the tremor types in just a second after we go through the answer choices, just so we can get a comprehensive understanding of tremor. Alright, so first answer choice, deep brain stimulation. So this is usually second or third line for a lot of tremor cases. Why? Because it's pretty invasive and can be associated with complications of any surgery of inserting the electrodes and having this done. This is usually done for drug-resistant Parkinson's disease. In the case of that tremor, we can stimulate the brain and activate inhibitory circuits. Thalamotomy is a similar case to deep brain stimulation. Usually it's a last case scenario where you lesion part of the thalamus in order to inhibit the tremor circuit. We'll also be going through the dopamine stimulation and the movement circuit in the brain in just a second. So these two are usually used for drug-resistant cases or people that don't respond to other treatments where their tremor is really bothering them. Alright, levodopa and carbidopa. This is used classically in Parkinson's disease. I'm betting most of you recognize that. And then the one thing that you should know is that this is not really a super first-line therapy. Why? Because eventually you get resistance to these drugs and they don't work as well, and they also have their own side effects. So usually you wait until the patient is over the age of 65 or has multiple comorbidities. So these are kind of postponed as long as possible in order to maintain good outcomes, because that resistance does develop. So you want the person to be have a positive impact for as long as possible. And these are also used for other conditions like generalized dystonia or restless leg syndrome. Now a little bit of a side tangent on restless leg syndrome. Do you guys know what other drugs you use for restless leg? Right, so it's other dopamine agonists. So we have here pramipexole and ropinirole are some other dopamine agonists like carbidopa and levodopa that use, as well as cobergoline, right? Pramipexole, ropinirole, cobergoline, and then we have our combo carbidopa-levodopa used in restless leg syndrome. Again, it's a tremor disorder, movement of the leg at night. Usually the patient's spouse will be complaining that they get kicked all night. And another thing that I've seen on tests is the association between restless leg syndrome and iron deficiency anemia. So you can get a microcytic anemia. So usually when you treat restless leg with either pramipexole, ropinirole, or cobergoline, you're going to want to put the patient on an iron supplement as well. So watch out for that. Alright, so moving on to clonazepam. This is a benzodiazepine, right? And we have a treatment for essential tremor that is primidone. So we have our two P's, propranolol and our primidone therapy, which are first line for essential tremor. But primidone is a barbiturate. So barbiturates like primidone are first line, but benzodiazepines are not. Why? Because their efficacy is still not that great for this disorder, and they also have potential addictive and withdrawal properties. So if you're going to use something for essential tremor, I would start with propranolol and then primidone if that doesn't work, and then you move on to your second and third line agents. Alright, next we have penicillamine. Penicillamine is used in Wilson's disease, if you thought this was Wilson's disease, because there's a potential inheritance pattern. We saw that his father also had it. This has a flapping tremor. And why? Why? Because we have something called an ATP7B mutation. And I have a video on copper metabolism, which you can watch after this. But essentially, ATP7B helps copper to get out of the liver and be excreted. So now we have copper accumulating in the body, and it really likes to build up in the basal ganglia, causing your flapping tremor. So another thing that kind of is mentioned against Wilson's disease is that Wilson's disease tremors are usually asymmetric. And you'll see that a lot of these tremors are asymmetric. We're going to quantify them in a second, symmetric or asymmetric, and put them in categories. But that's one of the things you really got to look out for in the tremor questions, whether it's symmetric or asymmetric, and then whether it's worsened by movement or better with movement. And also, the other thing about Wilson's disease is they didn't really mention any Kaiser-Fleischer rings of copper in the cornea, no hepatosplenomegaly, we didn't get jaundice or ascites because our liver also contains a lot of copper. Remember, our ferritin and hemosiderin build up here. So those are not mentioned in the question, so again, leads us away from penicillamine. And then we have propranolol, which is really our first-line therapy for every essential tremor. How this is theorized to work is that it inhibits the spindle sensory fibers in the muscle in order to stop the potentiation of this tremor. So it stops the onset, because that's how it's theorized to work. We have sensation from the muscle going to the brain and then causing a loop, reinforcing the tremor. Essential tremors usually come with a positive family history, so watch out for that. We have people whose family members will also have a tremor, so make sure you ask family history for these patients. And in our essential tremor, it's bilateral. So our patient had it bilaterally, which is an important clue. And it's worse with movement. Beta blockers are the first choice. All right, and if you don't get a beta blocker, you will get what? A barbiturate like primidone. If it's really mild, you can hold off on giving medications. But in this case, it was causing the patient some distress, some impairment, so he was given the propranolol medication therapy. So let's discuss our tremor types. We'll go from resting all the way to intention and kind of describe as simply as possible what's going on with each. So let's go up the ranks. So resting is exactly what it means. The tremor is at rest. So the person's hands are beside their body, they're not moving, and they have a tremor. One step above that, in terms of action, we have action tremors, okay? This includes both postural and intention. But let's talk about postural just for a second. What does postural tremor mean? It means our guy is standing with his hands extended, and now these hands are shaking. That is a posture. So asking the patient to raise their hands out in front of them against gravity, and the tremor is visible, that's a postural tremor. Right? And then if we move one step above that, it's an intention tremor, and that's asking the patient to not only lift their arms against gravity and retain a posture, but move their arm in a certain direction, and they'll have a zigzagging pattern. Okay? And that's the finger to nose test you see in stroke patients, where they zigzag, meaning they have likely a cerebellar stroke. Okay, so it's different levels of movement. Resting, our guy is at rest, he's not moving at all, and you see the tremor in his hands. I'm just using the hands here as an example. We can have different body parts that shake. But resting, you're not moving at all. Postural, you have your hands raised in front of you and they're shaking. And then intention, you are moving your arm. All right. Next, let's talk about each one individually. So resting tremor, this is also classically called a pill rolling tremor because it looks like you're rolling something in your hands. This is really caused by Parkinson's or drug-induced Parkinson's. So anyone who has a low dopamine state, such as in Parkinson's, or let's say they're on a dopamine antagonist or inhibitor in an antipsychotic, that's a drug-induced Parkinson's, we can have a resting tremor. The onset is at rest, okay, and we have associated symptoms of rigidity, bradykinesia, so you're not moving around really well, and postural instability. And this tremor, paradoxically, is improved by action, so watch out for that. Our Parkinson's patient, when they move, their tremor gets better, but it's worse at rest. So each of these tremors tells you a little bit about better and worse in the original definition. Then we have our two postural tremors, our essential and our physiologic. So how do we differentiate them? These are both fine tremors, okay? Postural tremor has a hereditary component, so if you see someone with a family history like in our guy, where the father had it and he needed treatment, you're more likely to have it in the children. Physiologic tremor is, let's say you're under a lot of stress or you've had 10 cups of coffee, you can have a physiologic tremor. Anyone can get these physiological tremors. but they're more likely in some people than others based on their predispositions, obviously. So with our postural tremor, we have it worse with certain postures, so raising your hands against gravity, like our figure right here, and it's also worse with voluntary movement, so like going to grab a pencil. Now, I can see how you would get confused with intention and postural tremor. Our intention tremor is only when you're moving to grab the object, and you'll see a very classic zigzag pattern. Our postural tremor is very fine, so this is more of a coarse tremor, right? Big zigzags. Our postural tremor is a very fine zigzag, and they're going to grab the object, and they also have it in the specific posture. Our intention tremor does not, okay? So that's how you differentiate them. Even though they're both moving towards an object, this is very coarse and the postural tremor is not there, and this one has the postural tremor and the very fine zigzags when moving towards an object. You can see this tremor in the head, that's another key feature, and it's better with alcohol. So drinking makes it better. Make sure you ask this question if you're interviewing someone who you think may have a postural tremor. Physiologic tremors, we discussed it. You're under stress, you're under the influence of 12 cups of coffee, you're going to have it worse. You raise your hand against gravity, you can have a tremor. All right. Let's say you are hyperthyroid or you have a lot of thyroid hormone in your system. That increases your catecholamine effect, and then we have another sort of tremor situation that looks very much physiologic. The neural exam is normal, and we are managing it with sympathetic stimulation management. So you want to reduce the coffee intake, reduce the stress load on the person. All right, and then intention tremor, we discussed it's a cerebellar stroke, okay? It can be caused by more things than just a stroke. We can have multiple sclerosis, chronic alcoholism, which attacks the cerebellum. Watch out for that. We have our big zigzagging motion tremor, ataxia, hypotonia, gait instability. These are all cerebellar signs, as well as nystagmus. So you're not really going to see these with the other tremor types. And it also occurs it also gets better at rest. So in our Parkinson's resting tremor, it is worse with rest and better with movement. In our intention tremor at the other end of the spectrum, it's worse with movement, better with rest. So just remember that. So I hope this clarified these tremors a little bit for you, and you can revisit this table whenever you like. Okay, so here are dopaminergic pathways in our brain. Let's go through them one by one. And it gets a little bit confusing, so as long as you remember these diagrams and what inhibits what and what stimulates what, you should be fine. But I'll give you a general overview. So our direct pathway, what you need to know is that it increases movement. And our indirect pathway is responsible for inhibiting movement. So if, let's say we're putting a deep brain stimulating device in, we really want to stimulate our indirect pathway, right? We want that shaking to stop. We also need our direct pathway to induce movement. So let's start with how movement is induced. So the cortex is one of the stimulators for our striatum. Our striatum here, STR, is our control center for whether we're causing movement to happen or not. And this is the control center for whether we're causing the direct pathway to go or the indirect pathway to go. So let's say our striatum goes through our direct pathway. Okay, so our direct pathway, we have inhibition of GPI, globus pallidus internus. Okay, now we're inhibiting this, so now it can no longer inhibit our thalamus. Okay, and if our thalamus isn't inhibited, it can now go ahead and feed back into the cortex and cause movement. Okay, so I know this can be a little confusing with inhibiting the inhibitor, but just follow the pathway along and you should be able to get to the end result. Next, let's say our cortex stimulates our striatum into inducing the indirect pathway. So our indirect pathway is a little bit longer, and what happens is our striatum in our indirect pathway goes through our globus pallidus externus, and it inhibits it. So each time our striatum acts, I'm going to put it in red, it's an inhibitor. All right. So now that our globus pallidus externus is inhibited, it can no longer inhibit the subthalamic nucleus. So if it can't do that, our globus pallidus internus, which causes negative action on our thalamus, is free to go ahead and inhibit the thalamus. Now the thalamus can no longer go ahead and activate the cortex, which causes our movement. So if we're stopping this, right, our GPE, globus pallidus externus, which is also supposed to inhibit movement by stopping the subthalamic stimulation of GPI, doesn't work anymore. So we have our GPI acting. Remember, so our GPE and our GPI both cause negative signals. So this whole striatum, GPI, GPE, just remember they are inhibitors. And let's highlight our stimulators in green. So our subthalamic nucleus, our thalamus, and our cortex are all stimulators. So we have our stimulators here in green and our inhibitors in red. Okay, as long as you remember which one of these is a stimulator or an inhibitor and which order they go in, you should be able to memorize this pathway pretty easily. Alright, so let's go through the substantia nigra and act on these pathways, okay? So the substantia nigra produces dopamine, right? And you need dopamine for smooth flowing movements. And so our substantia nigra is also causing us to be able to move. So whether it's acting on the direct or it's acting on the indirect pathway, you'll see that it's inducing movement, right? So in our direct pathway, in which we're causing movement, our substantia nigra has a positive effect. So it acts via the D1 receptors, which are stimulatory onto our direct pathway, and our direct pathway then results in movement. If we have our substantia nigra pumping dopamine onto our D2 receptors here, which are responsible for our indirect pathway, we have these D2 receptors causing an inhibition of the indirect pathway. So our reduction in movement is essentially stopped. So we have more movement, okay? So here our substantia nigra is inhibiting the indirect pathway and stimulating the direct pathway via the specific types of dopamine receptors that are activated in each of these pathways. So it pumps dopamine, and dopamine works on D2 as well as D1. And you can see that it inhibits D2, causing the inhibition of the indirect pathway, and stimulates D1, which activates the direct. And here's a little summary diagram. So the green shows you which are the stimulatory molecules. So here we have our glutamate, which are corresponding to our cortex, to our striatum here. And our inhibitory signals are conducted via GABA. So just when you're looking through these diagrams, green is glutamate, red is GABA, except for when we're stimulating and inhibiting our dopamine. Those are dopamine signals. So here is a combination diagram that hopefully helps you simplify this concept. All right, so we talked about tremor, we talked about movement pathways. I hope this video was a good little review for you, and I'll see you in the next video.